review very fast the base and some of the stuff that are the super high yield part. Physiology is always has a super high yield. There's no low yield in it because with physiology you go with physiopathology. So and some of the physiology issue is pretty much about gases. You understand gases, you can understand the physiology itself. No, I don't. Okay, so let's start with some of the embryology parts that are super high yield that you saw in the past. I always ask you about this or put you a question about this. And Jakob, did you have how many questions did you have about the arch and stuff in the NBNE? Okay, is the usual the amount questions even USMLE? You're always going to have one or two questions about the arch. So this is why you need don't miss them. Always boring to remember them, but if you go over the embryology itself, it's more interesting. So the remember there's six arch, and the one of the arch, which is arch number 5, never counted, or in the question actually is going to tell you which one is missing, or they're going to tell you some of the development, and the arch number 5 never shows it because it's the one that is going to disappear. So regression. So you start mostly starting from arch 3, 4, and 6. These are the main one. And remember, since you talk about aortic arch, is going to be blood vessel arteries. So arch 3 starting from the base of the aorta. So you're going to have the common carotid artery and the internal carotid artery. So it's about carotid in here. There's not much more to that. The arch 4, that is starting from the subclavian, the right subclavian, and that is the proximal part. The aortic arch itself starts from arch 4, and everything that is going to keep there, persistent there, and is going to lead you to the double arch, aortic arch. And then you're going to have the 6. The 6 goes mostly a bit lower, so it goes to the pulmonary arteries and the ductus arteriosus. So keep in mind, you know that by now. So the pharyngeal arch come from mesoderm. This as well are common question. The pharyngeal cleft come from ectoderm, and the pharyngeal pouches come from the endoderm. Okay, mesoderm, pharyngeal arch, ectoderm, pharyngeal cleft, and the endoderm, pharyngeal pouch. These are some facts that most of you know by now. Usually these are not questions. Some of them are not question asked, but it's always interesting to know them for reference point. So, for example, the in healthy adult 24 hours production of CO2 is going to be around 330 liters. Why this is a fact is important is just imagine that someone is in the cave, or it's an area where there's not much of oxygen, and then you need to know how much intoxication, how fast these people cannot breathe any oxygen anymore. So production by 24 hours to 330 liters. Obviously, this value can change depending on how fast you're going to breathe and how high your metabolism is going to be. But overall, the medium is going to be 30. Diffusion capacity of carbon dioxide, meaning how much the CO2 is going to replace the oxygen as the receptors. So it's a diffusion because it's a gas, and that is something like 20 times the one of oxygen. So this is why every time you have monoxide poisoning, the oxygen is going to be kicked out very, very fast and replaced by it. And this is why it's deadly. The average of alveoli wall in contact with capillary in both lungs is going to be 70 square meters. This as well is not a value that is super high yield as a question, but it's a comparative point, as you know, if it's a restrictive or non-restrictive type of disease. And if it's restrictive, you're going to have lesser of the surface wall comparative to the extensive one that maybe the surface is going to increase, but not the exchange itself. Diffusion capacity, that as well is a gas. So you talk about diffusion of CO2 is going to be between 10 to 30 milliliters per minute per millimeter mercury. This is a value that I suggest you to keep in mind. It's going to be handy for some calculation. And remember, calculation that they will give you USMLE a simple calculation. So you don't need much of calculator or stuff. So normal composition in venous blood, this one you need to know absolutely for the pH of venous blood. Venous, not artery blood, but venous blood. Um, and PO2 is going to be 40, and PCO2 is going to be 46. And remember, the PCO2 is a constant that you're going to find either in artery or in vein, although in artery is going to be around 40. But in vein is going to 46. And the saturation of hemoglobin is going to be 75%. This one as well is a value that you need to keep in mind. Peak expiratory flow rate, we're going to see the graph for this one, but this one as well is a value that I suggest you to keep in mind, which go from 400 to 500 liter. And if you have a hemoglobin, the increase of oxygen carrying capacity in the blood is going to increase it by 70-fold. This as well, it's a kind of value or basic hint that you need to keep in mind, because remember that the exchange is always between O2 or CO2, but sometimes it can be monoxide, CO only. The intrapleural pressure, this one we're going to see in a few minutes. Record pressure, so it doesn't mean it means it's the pressure that you're going to have between the pleura, and it's a pressure that is going to be kind of elastic pressure that extend and come back, extend and come back. But the value need to be depending on if you take deep breath or not. The value is going to be -4 millimeter mercury. Yes, we're going to see that. Yeah, exactly. So if you have this value that you're going to change, that if you have pneumothorax, obviously the pressure is going to be higher. What does it mean? It means that your lung is going to collapse. So this is why you have the intrapleural pressure is a very important pressure. And the value that is the constant value that is -4 millimeter mercury, which you need to know, is if you have surfactant. If you don't have surfactant, the lungs are going to collapse. There's no surface anymore. So the intrapleural pressure at the end of deep inspiration is as well -4 millimeter mercury, or 4 millimeter mercury. This is something we're going to see as well, and how to calculate them. And the intrapleural pressure during expiration is going to be -2 millimeter of mercury. Hypoxia, what does it mean? It means that the pulmonary vasoconstriction is happening, and this is what causes hypoxia. So there's less oxygenation. But if you have pulmonary vasoconstriction, you're going to have pulmonary cerebral vasodilation. Keep that in mind as well. This has been questions, and I did ask you those type of questions in the past. The lung, in the lung, angiotensin 1 is converted into angiotensin 2. You know that by the pneumocyte type 1, and that is going to maintain the resistance within the capillary within the lung. And in the transport of CO2 is maximum in the form of bicarbonates. Remember, it's a balance between both of them. The CO2 will lead to respiratory acidosis, as the bicarbonates will lead to metabolic alkalosis. And the compensation is going to be between CO2 and bicarbonate. And remember that bicarbonate is in relation with chloride as the receptor surface of membrane. So in the step, as you know by now, that you will have at least, it could be between 2 to 4 questions per block, as much as it can be just 2 questions for one block. But acid base is always, always, always asked. Why? Because in practice, this is something that is super, super important. This is how you're going to manage the fluid. This is how to manage the oxygen, etc., etc. So by now you should know that respiratory acidosis is about CO2 and metabolic acidosis is about bicarbonate or H plus that is increasing and bicarbonate that is decreasing. So and always look for is there compensation and not or not. And remember that the compensation most commonly are going to happen after 4 hours, starting from 4 hours. The other difference is going to be that if you have an anion gap that is high, meaning more than 14, you know that you have metabolic acidosis. And most commonly, there are some diseases that you have metabolic acidosis base, and this should be compensated, and that is diabetes. And some of, for example, CO2, you know, to a respiratory acidosis from beginning. So, how are you going to recognize respiratory acidosis? Remember, if you do the formula as the pH equal bicarbonate divided by CO2 or H plus, from that formula you can determine what is your pH and what is the changes that can happen. Just knowing that formula is more than enough. You don't have to remember anything else. That one would be more than enough to determine what is going on as a pH change. And if there's compensation, no, I mean compensations. So just keep it in mind. Other than that, respiratory acidosis is going to be obviously CO2 that is going to increase, and the pH is going to decrease because of pH divided by CO2 that is leading to decrease. And the normal pH, remember, is going. What is the value of normal pH? Yeah, around that. Just keep in mind, yeah, around 7.4 will be the median one, but yeah, 35 to. At what level the pH it means coma and death? 6.8. Yes, 6.8 exactly. Starting from that, there's no return, as well as 8 for alkalosis. So if you have an increased CO2, what happened to breathing? Is it increase or is it decrease? I said if you have an increased CO2, what happened to the breathing? To the frequency of breathing? Is it going to increase or is it going to decrease? It's going to decrease, yes. Why did you say increase again? You answered correctly in the beginning. Yeah, decrease. When you decrease, it means you bring less oxygen and CO2 is going to build up. So, as a compensation, you should have the bicarbonate increasing if the CO2 increase just to compensate it. Now, if you have an alkalosis, obviously CO2, respiratory alkalosis, CO2 will decrease, but and the pH will increase, and for that bicarbonate should decrease. And remember, bicarbonate is about metabolism. Metabolic acidosis and alkalosis, well, the CO2 might change, but it's going to change as compensation. So, but obviously, you're going to have the pH that will decrease in acidosis, increase in alkalosis, and that is caused by decrease in bicarbonate for metabolic acidosis, or increase alkalosis is going to be an increase bicarbonate. And remember as well that metabolic acidosis might cause by an increase of H plus and vice versa for the alkalosis. But the CO2 will change independent of the composition that is going to bring. So how you regulate your ventilation is going to be by PCO2. If you have an increased PCO2, you have hyperventilation. You have decreased PCO2, you're going to have, it means you have hyperventilation. Um, and this is how it goes. So CO2 increase is because you have hypoventilation. CO2 decreases because you have hyperventilation. But every time you have an increase of PCO2, your body should react by increasing your ventilation, and vice versa. So it means, for example, someone that has a chest injury, one of the things that is going to happen is going to be increased CO2 because of uh, pain during the breathing. So they're going to decrease their breathing. So remember that the changes in the H plus is going to be felt by chemoreceptors, and those are the central chemoreceptors, and you have chemoreceptor all over the body. Um, and the peripheral chemoreceptors are going to respond as well. So the central will be H plus, but the peripheral is going to be mostly about PO2, PCO2, and H plus concentration within the blood, arterial blood. So some definitions and where to find them. Those as well are easy question, basic question that you will find just to catch up some point. Obviously, that you're not going to find them all the time, but sometimes you might. So hypoxic hypoxia. So anything that has to do with hypoxia, it means that you don't have much of oxygen going on. And where are you going to find that? Obviously, anywhere the pressure is so high, so the high altitude and the respiratory disease, obviously they cannot breathe, so the CO2 increase. And what are the tests that you're going to use for that is the PaO, so the arterial pressure in oxygen. The anemic hypoxia, when you have anemia, so you cannot have much of transportation of oxygen. You see this in severe type of anemia and severe type of hemoglobinuria. So you're going to have anemia, obviously, but CO poisoning, because like I said earlier, that CO is going to take the place of the oxygen. So here you're going to, the testing that you're going to do, obviously you need to prove that this patient is having anemia or not. The hemoglobin would be a big part of it, and also you need to do the peripheral gases and to see if they have CO poisoning. And the CO poisoning, remember, winter time, like our time right now, is the best time you have in this. And so you're going to use the hemoglobin concentration and oxygen content of hemoglobin concentration as the best test. So gases of the blood would be good enough. Stagnant hypoxia, it means that this is something that is by hypoperfusion, and you're going to see this a lot if the pump, which is the heart, is not following the beating. So cardiogenic shock is going to be one of them. This is what you call it stagnant, so it means do not move. And this is where you're going to do as a testing the AV differentiation on oxygen. And remember, those are going to be the question that are going to be asked. Histotoxic hypoxia, those are usually by poisoning. Cyanide is one of them, and cyanide love to remove oxygen from the hemoglobin. And this one as well, you're going to do the AV differentiation of the pressure of oxygen. And in this one, most of them you're going to use the arterial, but this one you're going to use the venous blood and AV difference on the relation with the pressure of oxygen. So if you talk about hypoxia, how are you going to recognize it in the clinical setting? And so obviously you're going to have the oxygen affinity that is going to decrease either because you have an issue with the breathing, or you're going to have an issue with the hemoglobin itself, or you're going to have issue of the amount of red cells that are not there. and so you're going to have that the PO2 is going to be very low. Usually, when you have hypoxia, when you give mask of oxygen, the response is very good and right away. And one of the example usually that I give, especially if you have if you are you have been EMT one day or work in the ER, you're going to see it by yourself. Is when someone come with the CO poisoning and you give them oxygen, from the pink color that they have, they become very normal color, red color, and that is within minutes. And so that is hypoxia. The hypoxic hypoxia is most common type of hypoxia. So keep that in mind. It means dropping of oxygen for any reason. Go into mountains, for example, but you compensate very fast. And the causes is the pulmonary arterial pressure that can rise, and that for many reasons the pulmonary pressure can rise. Carbon dioxide is the most potent stimulus for the respiration that we saw. So respiration as in the medulla oblongata, or as the chemoreceptors, or within the lung itself. This is why you're going to have immediate reaction as hyperventilation when this happens. Carbon dioxide affects your center by influence on H plus concentration CSF. Keep that in mind. This has been a question actually. Um, I don't remember. Amdi, was it you that sent me that question about this? No, or was it different? No, it was different. Um, but just remember that the CO2 is going to apply on the H plus within CSF, and this is why you're going to have irritation, multi-irritation, because of decrease of all the oxygenation within the CSF and in the brain itself by circulation. But overall, you might have the causes of the decrease of CO2 is going to lead you to too much oxygen is not good, uh, too little of oxygen is not good. But any sign of hypoxia is going to be the brain that is going to feel it, and that you're going to have depression, you're going to have change of mood, aggressiveness or tiredness, confusion, coma, death. And obviously you're going to at the beginning you're going to react to it because you still have oxygen around you, so the but with time ventilation is going to decrease and cellular activity is going to decrease, and that is yeah, the selfish brain is going to take everything for himself until the organ is going to they're going to shut down one by one, and then is death. Oxygen toxicity, this is as well many, not as many questions. It's all in the head, yes. Oxygen toxicity as well is something that you need to keep in mind. Uh, there is some specific question about it. So oxygen toxicity will be either by giving a curve or talking about the birth effect or talking about babies that newborn that you're going to give them oxygen and what is the consequences of too much of oxygen, especially for the eyes. So, so this is a big question. So oxygen toxicity are caused by you can have the CNSF effect, which you call the birth effect. What does it mean? It means you start to be irritable if you have too much oxygen. Like I said, too much oxygen, too much CO2 is not good. The muscle, because they don't have any oxygen, they start to twist, and you're going to have lactic acid production from that. You start to have conversion, dizziness. Dizziness can be one of the first sign. Irritability and dizziness would be the first sign of oxygenation toxicity, and then disorientation come, and then convulsion happen, and the muscle problem. And then you're going to have the pulmonary effect. Pulmonary effect is what you call the Smith effect. And that is because where the oxygen come from mostly is going to go to the lung. You're going to have irritation of the trachea and the bronchi, so they become inflamed, which will lead to a pulmonary edema and congestion and atelectasis. So collapsing of the lobes one by one. But the congestion is because you have too much of oxygen coming and not enough red cells. So the red cells start to slow down because you have enough oxygen in the body. But the direct effect, like I said, for babies, so this is a question that can be for step one, step two with the pediatrics and newborn, is going to be the retinal damage. And you're going to have the retina becoming completely white when you have oxygen intoxication, and the blindness can happen. The other issue that can happen with it is going to be the retrolental fibroplasia, which you're going to have a shrinking of the retina, and so all the eye is going to be destroyed. Remember, oxygen can burn as well, so burn out of the tissue, because when you give a lot of oxygen, what's going to happen? Your metabolism is going to go sky high. So it's like exactly if you had hyperthyroidism as a crisis. And so you increase the metabolism so high that you're going to burn out. And your temperature, body temperature, is going to increase, and they look like a fever, which is not a fever, but is the same mechanism as a fever. And probably this is one of the reason of the what do you call the see these people that are found burned and without any reason, that just have a combustion. So that can be any reason, or can be mitochondria reason. Um, the other question that I'm going to be asked as well is about mountain sickness, because time to time you have people going to the mountains, you have climber, etc. So that is the reaction of the hypoxia in high altitude. I remember people are going to get used to it usually around 3 days, and many of them are going to have and need to have oxygen mask until the erythropoietin kick in and the polycythemia start to kick in. Um, and obviously, this is going to the mountain sickness happen very fast, within 8 to 24 hours after their arrival, and they're going to stay, like I said, at least 3 to 4 days until polycythemia is going to happen. And some people it can happen up to 8 days. So it depends if you are anemic or you're not anemic, and if you're male versus female, etc. But until there's and if you have healthy kidneys as well. And the so you're going to have a low PO2 that is going to stimulate the increase of ventilation. This is what's going to happen, and you're going to blow out a lot of CO2 from it. And if you blow a lot of CO2 from it, and you have an increase of and you have decrease of the PO2, this is going to inhibit the respiratory center, and that is going to lead you to respiratory distress. Keep that in mind, because these are the questions that are going to be asked. So, what will be the symptoms? One of the symptoms that you need to fear the most, there are two of them, that is pulmonary edema and cerebral edema. So, cerebral edema, because you're going to have cerebral vasoconstriction, and remember, within the lung, you're going to have vasoconstriction. And so, in the lung, you're going to have increased permeability, that which lead you to dyspnea, and cerebral edema, you're going to have the first sign are going to have to be headache, irritability, insomnia, weakness. Especially if you have insomnia, you need to ask your patients to, or if you're outside, far from any hospital or anything, to not sleep. This is why people in the cold that don't sleep, or they maintain always awake for many reasons. This is one of the reasons, and the other reason it's to maintain metabolism. If you sleep, your metabolism decrease, your blood temperature, or your temperature, core temperature, is going to decrease, and this is how you end up that. The other signs, which are a bit faster to happen, and that is the effect of the expansion of gases within the GI, which lead you to nausea and vomiting. So, nausea, vomiting, dyspnea, headache, irritability, and everything else are going to be cause of the low oxygen, and they blow out faster of CO2, trying to bring as much as possible oxygen inside. So how How are you going to adapt to it? Obviously, like I said, the erythropoietin are going to start to kick in massively, and to have as much as red cells produced by the bone marrow. But the first reaction that you're going to have is going to be hyperventilation. This is why the effect of low PO2 and blowing CO2 that in the respiratory center. So the hyperventilation are bringing a little bit more oxygen, but although there's not that much, but you bring a bit more, which is going to increase the hemoglobin, which will lead to the polycythemia, immediate polycythemia, but erythropoietin will be the biggest one to create that. Obviously, the mitochondria are going to increase because metabolism, the cells need oxygen, so the mitochondria, being the lungs of the cells, they need to work 100%. The cardiac output is going to increase to try to have all the cells having oxygen, and in situation where the oxygen will be decreased. Since the hemoglobin is going to increase, the 2,3 DPG is going to increase with it, and that to try to reach and cap all the oxygen possible, and that this is what would make the 75% of oxygen within hemoglobin. And then you're going to have the gas are going to diffuse. They're going to try to increase the diffusibility of it, to have more exchange with the tissue. And obviously, if you have polycythemia, you're going to have reticulocytosis because the bone marrow are producing more new red cells, and you're going to see them as reticulocytes. Exactly as if you have an anemia of regenerative anemia, where, where the bone marrow are going to produce more of the red cells. The pressures. The pressure that's these are values that you need to remember. These are values that are also asked in the questions. I know that many of students do not remember all these values, don't want to remember these values whatsoever, because there's other stuff to try to remember. But these are stuff that you're going to see all the time. So you're going to see it in TV, you're going to see it anywhere. So the big pressure that you need to know is going to be the atmospheric pressure, which is 760 millimeter mercury, which represent around 630 millimeter mercury here. And the pleural pressure, this one is slightly lower than the atmospheric pressure, 756. And then you're going to have the pressure between the layers, which you're going to see in a few minutes. And then you have the intrapulmonary pressure, and this one is going to vary if depending on the breathing, inspiration or inspiration, and the pressure is going to vary really within the elbow line. Then you're going to have the formulas of the airflow, pressure, and resistance. So remember, this is something very important for the airflow. And if you have any obstruction of the airflow, it means you're going to have an hypoxia, no matter how much hyperventilation you're going to have, until you're going to manage the airflow. So the airflow can be obstruction caused by foreign bodies, can be obstruction caused by mucus, can be obstruction caused by spasm, obstruction caused by stenosis. Um, so you're going to talk about the obstruction can happen from the nose or the throat up to the trachea and bronchi. Those are where the obstruction is going to happen. Once it goes to the alveoli, these are mostly the flow of the air that would be an issue, and the thickness of the walls with the four lows of the gases. So the airflow is calculated by the difference of the pressure divided by the resistance. And remember that the airflow is directly proportional to the pressure difference between the mouth and the nose, which is outside. If it's outside, it's atmospheric, and then the difference with the alveoli. This is one of the big difference. Like I said, the obstruction will happen within between the nose and the bronchi. And then the airflow is inversely proportional to airway resistance. So how much resistance you're going to have if you have an obstruction, for example, More obstruction is going to have more resistance is going to increase, and less airflow is going to happen. So this formula, know it. And then area resistance, how are you going to calculate it? This is typical physics, um, and that is about the tube, the law of the tubes. So the resistance will depend on the gas, the viscosity of the gas that you're going to transpire, divided with the airways. Longer the airway is going to be, more you're going to have a resistance that is going to build up, and the radius of the airways. This is almost the same formula as the blood vessels, how the blood flow is going to the blood vessels. So you're going to so the area resistance will be the 8 multiplied by the length of the airways and divided by the p power 4 radius of the airways. This is a formula that would not ask you formula per se this way. Sometimes I saw in the past some of the questions where these formula can be handy, but usually they will not ask you really about formula. They will ask you about numbers, and sometimes it's knowing the formula to know the numbers. So this is why you need to keep them in mind. And who love this type of questions? Usually are PhDs. So the respiratory pressure is always described with the atmospheric pressure. So what is atmospheric pressure? Is the pressure that is surrounding you. Uh, it's uh, it's a constant type of pressure that might change with the height, but overall it should be always constant. So you need to look at the atmospheric pressure with the level of the sea, and more you get out, higher and more is going to change. So you're going to have this atmospheric pressure. It can be negative respiratory pressure, than or less than the atmospheric pressure, or it can be positive respiratory pressure, so greater than the atmospheric pressure. This is what you're going to see with the breathing itself. The intrapleural pressure is always less than the intrapleural pressure and atmospheric pressure. Keep that in mind. If it's higher, you cannot breathe. So that is a must. Intrapleural pressure is always less than intrapulmonary pressure and atmospheric pressure. So what do you need transpulmonary pressure for? Is to keep the airways open. So this is why when you go to space, because the pressure is so high that the lung will collapse, completely collapse. So this is what you need in the Earth. You need to have the transpulmonary pressure that keep it open. So the transpulmonary pressure is the difference between the intrapulmonary pressure and intrapulmonary pressure. This is how you're going to calculate it. It's going to be the difference. We're going to see it again, but for now, just remember it's going to be the difference between the intrapulmonary pressure and the intrapleural pressure, and you calculate your transpulmonary pressure. And remember, you should find it uh, kind of a differential, so between numbers. How are you going to change the airways resistance? This as well is the basics, and usually here you're going to have multiple factors that are going to be important, and a lot of questions about around these type of things. And actually, these are the questions that you hate. It's a kind of molecular biology type of questions, kind of, um, and it's also CNS type of questions. So the change in airway pressure is going to depend on the airway diameters. That is one. The change of those diameters, vasoconstriction, vasodilation, or increasing or decreasing, is going to lead you to a mechanism that is going to change the resistance itself in the airflow, as we saw it in the formulas. Remember, increase the resistance or decrease the resistance has an impact on the airflow. So innervation are going to be important in here, which is the autonomic nervous system and the parasympathetic stimulation. So the sympathetic stimulation usually are going to act on the smooth muscles. and the innervation of all these smooth muscle by anything that is adrenergic. So the sympathetic stimulation usually have an impact on the beta 2 receptors in the lung. So they're going to stimulate the beta 2 receptor. Once these are going to happen, you have a relaxation of the smooth muscles. If you have relaxation of smooth muscles, then the airways. So you have the radius that is going to increase, thus the airway diameter is going to increase, and that means that you're going to have decrease of the resistance to the airflow. So you're going to have some better airflow going in. Now, so this is why if you give a beta 2 agonist, and remember for the USMLE, they love to give you someone that has heart issue with asthma and what medication not going to give. So this is why you need to know your beta blockers, and you need to know the beta blockers that you're going to give for someone that has a respiratory issue versus someone that do not have a respiratory issue. So the beta 2 agonists like epinephrine, isoproterenol, and albuterol usually do have an effect on relaxing the bronchial smooth muscle and dilation of the airways. And this is what you're going to give it. These are treatments given to asthmatic patients. Remember, asthmatic patient is an inflammation of bronchi. You have a bronchoconstriction and mucus increasing. So you have pretty much resistance and narrowing of the airflow. So the best thing is, especially when you give albuterol, the airways open up right away, systematically within seconds, allowing them to breathe. Obviously, it's going to depend on what type of asthma you're going to talk about, the severe asthma versus non-severe asthma. And albuterol is one of the treatment that is used every day by asthmatic patients. You see it all the time. These kids having this pump put in their mouth all 5 minutes. Usually, don't put it too much, otherwise you can have the kind of toxicity which you can find yourself as kind of bizarre. And it takes a few seconds, but you're going to feel dizzy and all this. So now the parasympathetic stimulation in that situation is going to be obviously contrary from the sympathetic, and you're going to use obviously this is parasympathetic, so chorinergic nerve, and those usually parasympathetic in the lung, in the bronchi, they're going to stimulate the muscarinic receptors. Remember, this is post ganglia. So post ganglia, remember preganglia is going to be nicotinic, post ganglia is going to be muscarinic, always with parasympathetic. So you don't bother much yourself. And remember, as a review, that the preganglionic for sympathetic is going to be acetylcholine, the postganglionic will be either adrenergic or adrenaline or or noradrenaline, as the parasympathetic is going to be preganglia, acetylcholine, postganglia, acetylcholine. That doesn't change. So here you're going to have, since it's postganglionic, you're going to have muscarinic receptor stimulation that will lead you to constriction, contrary from sympathetic. And if you have constriction, obviously you have narrowing of your bronchi, and that means the airway diameter is going to decrease. So it means the resistance is going to increase to the airflow. So you're going to have less air going inside. And this is something that is happening every 5 minutes. Every minute within your lung, depending on the need. So now the pulmonary vascular resistance, the PVR, how are you going to calculate this? This you're going to have to need to know the physiology of the heart, because you're going to include the cardiac output, you're going to include the pressure within left atrium versus the pressure within pulmonary artery. Because the pulmonary vascular resistance is calculated by the difference between pulmonary artery and left atrium and divided by the cardiac output. So remember, pulmonary artery is the pressure within the pulmonary artery itself, and the left atrium is pulmonary capillary wage pressure that you're going to use. What is a normal pulmonary capillary wage pressure? Yeah, 12 or less than 12, commonly. So know this value, because this one you can have several questions. It's about if the cardiac output of this individual is going to increase, what happened to the pulmonary vascular resistance? That is the one of the biggest questions. That and vice versa, obviously, which allow you to understand pulmonary hypertension. Okay, so now this is one of the is it's not that complicated, but just for what happened with what we talked about so far. So now, when you are at rest, this is the end of expiration. So when you have the end of the expiration, what happens is that the barometer air pressure should be 0. So normally the barometer pressure should be the same as the pulmonary alveolar. Alveolar versus the external thing, so barometric pressure. So obviously there's no air going in, going out. So the pressure within the alveoli is going to be 0. There's no air. There's no thing going on. So now you're going to start to take a deep breath. So what happened is the diaphragm is going to start to contract. The value for the barometric air pressure still 0, but in this situation you're going to have that this barometric air pressure is going to be higher than the pulmonary alveoli. So why is it higher? Because you need to push the wall out and to expand the alveoli. So if it was lower, what does it mean? It means it's not going to expand it, but it's going to collapse them. So this is going to allow actually the air moving. So what will be the pulmonary alveolar pressure is going to be negative, because since the barometric air pressure is going to be 0, it's supposed to be less than 0. And usually the value for it is going to be -1. So the alveolar volume is increasing from 0 to -1. So what happened in this situation? So remember that by extension, you're going to have the thoracic volume that is going to increase the alveolar volume, because it's going to be filled with air, and decrease alveolar pressure. So do not mix up, which some do. Don't mix up volume with pressure. It's very different. Pressure is something that is going to push. Volume is air, is gases. So this is why the diaphragm is going to contract and the walls start to expand by this pressure, this volume that is increasing the pressure within the wall. Now, now you're going to have the end of inspiration. So air, it reached its maximum, everything's going to stop. There's no air movement, so this is going to be exactly like end of expiration. Same deal. But this one, the only difference is in here, the alveoli are bigger, because are bigger in here, in the end of inspiration, and smaller in expiration. And then you need to breathe out. So when you breathe out, what happened to the pressure there between the alveoli and the barometric pressure, they're going to reverse themselves. So the volume in here is going to create a pressure that is pushing the wall, pushing the air out. So obviously the alveolar pressure is going to become positive. So it's going to become +1. That will allow to be bigger than the barometric pressure. And by doing that, all the muscle of your thorax are going to push the air inside, and the diaphragm as well, that will relax. You're going to push all the alveoli air outside, which allow the increase of pressure and the exchange of volume that comes out as a CO2. So the thoracic volume in that case is going to decrease. This is why one of the questions that associated with this one is going to be what are the muscle of expiration, what are the muscle of inspiration. So the relationship between the pressure is going to be, so you're going to have the wall, parietal wall. You're going to have the pleura. So the pleura, you need to look at it three ways. You need to look at it the parietal one, the visceral one, and the between. And it's the between where you're going to have the what we call the intrapleural pressure. So the intrapleural pressure is going to be the difference. Is going to be a value of 756 millimeter of mercury, with the differentiation of -4 millimeter mercury in regard to the intrapulmonary pressure, which is 760. And remember, this is going to be kind of zero because it's atmospheric, the barometric atmospheric pressure. So the intra pressure and pulmonary pressure is kind of constant. So you're always going to do the difference between the intrapulmonary pressure versus the intrapleural pressure to have the difference between what is inside the lung and what is inside the pleura, which is the transpulmonary pressure. So you're going to find it around because it's going to be the difference between them. So 760 minus 756 is going to be around 4 millimeter mercury. But inside it, you're going to have a differentiation that is always going to be negative to allow it to expand and collapse. So these are values that you need to know and to understand. So as definitions or facts, during inspiration, the intrapleural pressure are going to become more negative, as we saw it in the breathing. The respiration stop in late expiration. Why? Late expiration, there's no more that you can put. So the respiration is going to stop. Obviously, if you keep going with it, you're going to blow up your lungs and create fistulas. So why of it is because there's no compression anymore of the airways, since everything becomes zero. The total lung capacity is going to depend on compliance. What does it mean, compliance? It means the ability of the lung and the alveoli to expand. And surfactant would be super important to allow that. And obviously, all the pressure, atmospheric pressure, pleural pressure, all these as well are going to help. But the number one, if you have to answer this question about compliance, think about surfactant. This is what allow the increasing the surface area and increasing the volume and the spacing within the alveoli. Nitrogen washout methods that detect functional residual capacity. Remember that nitrogen, it's it's a weight of calculation, but this is something that does not stay in the body. It goes in, goes out. This way is going to be a constant type of level. The azote as well. Uh, so, so you use nitrogen. Remember, this has been one question. It's not a common question, but is time to time you have it popping up. Functional residual capacity. The FRC is not estimated by spirometry. Keep that in mind as well, because this has been what students call tricky questions, because you think that everything is done by spirometry, but the FRC is not. This is the only one that is not. Keep that in mind. Slow and deep breathing are the most economic way of breathing. It means that you go slowly in breathing. And remember, us human, we don't know how to breathe. A lot of us do not know how to breathe, unless you do sport regularly. Remember, breathe in by your nose, breathe out by your mouth. This is what you apply within when you exercise. But as a common individual, where you're sitting right now, you breathe in and breathe out by your nose, not by your mouth whatsoever. Sometimes you might breathe in by your mouth, depending on the dryness that is in your room. Remember, and especially in winter time, this is where your nose will be drier than usual because of the heater, and there's not much of humidity because of it. And so you're going to breathe from your mouth, which will be drier as well. Um, but the best breathing, and this is what you. Oh, so because what you do is you do a lot of sport. So this is how you get, yeah, this is how you get used to it. Anyone, I didn't do sport for what? I didn't play any soccer game for I don't know how many years. Uh, so everything's been a thousand years. Yeah. uh, so you're not going to think of it. Everything is reflex. But as a surgeon, what you're going to do, since both of you want to go to surgery, you're going to, before surgery, you recommend your patient to learn how to breathe. Why? It's because this will decrease the mucus within the lungs, first of all. They're going to help them better with the pain because you breathe in, breathe out, and you know how to do it, the pain decrease. And as well, sometimes before there's some people when they have pain, they increase the breathing. That is to increase circulation, decrease the pain. But slow and deep breathing is going to be the best because you fill your lung with a lot of air and you take time for the CO2 to come out. That is what is recommended usually. So the process of respiration. So the process of respiration, obviously, you're going to have two big parts of respiration by definitions. Keep the levels. Either, yeah, you can use bottle or you can use paper bags to ask them to breathe out in paper as much as they can to make them cough, and by coughing they're going to release all the mucus. And if you don't have that mucus, it means less respiratory infection post surgery. So that is physical therapy. So depend where you are, but I didn't see here much of doing this, especially for big surgeries like the 12 hours, 18-hour surgery. That help a lot. The 1 hour surgery, even for atelectasia, it helped the lung not to collapse. Now, um, so yeah, so for breathing and respiration, remember you're going to have two parts of respiration. One is the lung, gas exchange. By definition, respiration means gas exchange, heating oxygen and CO2. So you're going to have the lung one, which is the alveoli, and you're going to have the tissue one. And the between the tissue is going to be the transporter, which is the exchange as well within the red cells. So remember that a lot of these gases are going to be within the plasma. Some of the gases will be in the plasma, and most of it is going to be within the cells. But the process itself is going to be between breathe in, breathe out, exchange between the alveoli, and then the exchange, the transport, and then the exchange within the cells. That is the mostly the four aspect of it. And remember, all this is going to depend as well as the conduction of the air within the airways. So, by definition, what is pulmonary ventilation? It's just a movement of the air within the bronchi and then going to your alveoli. So that is part of the external respiration. So it's going to happen, breathe in oxygen, release CO2. And within your red cells and within the alveoli, release CO2, pick up oxygen. Within your tissue is going to be pick up CO2, give in oxygen, and then you're going to have the trajectory between the lung to the tissue and then the tissue to the lung. The importance of understanding this is going to be the pressure differentiation. Those pressure differentiation will be very important for the gases. This is how you're going to calculate the ABG by arterial gas or venous gas. but mostly you're going to use arterial glass. And remember now, to do that, you have the oximetry with the finger thing through the capillaries. But so that is the pulmonary ventilation. Then you have the external respiration as the exchange with the blood and stuff, and then you have the internal respiration that is from the blood and the CO2 once again, and then you have the cellular respiration. So cellular respiration is a bit more complex. So this is usually you do this in the biochemistry part of it. Why? Because you're going to have a lot of glucose and pathways and the amino acid pathways and fatty pathways that are going to be intricated between each other to release the CO2 and using the oxygen. So because of this oxygen coming, you're going to have the breakdown of these pathways once again. And remember that all this breakdown, cellular respiration, is happening within the bacteria, mitochondria. Remember, for humans or for animals kingdoms overall, mitochondria are the old bacteria, and in plants, these mitochondria are the chloroplasts. So both of them do have the function of breathing. And remember, the breathing is going to be around the cell membrane. So I suggest you to go back to the biochemistry and review the mitochondrial physiology itself with respiration. You have a lot of questions about chemistry about it. And you're going to see that iron and exchange of electrons are going to be very important within membrane. We did cover this one time or another in biochemistry. So this breathing is going to lead to what? It's going to lead to the ATP. And this ATP is super important for many reasons, and because this is the energy that you're going to produce. And remember, right now, when they ask you questions about the pathway of glucose, fatty acid, amino acid, that might ask you the general question about how many ATP are produced by each of them, 36, 32, 38, or 4. But before the old question, the USMLE question, that will ask you in detail what was the production by each pathway. So glad that now they don't ask us this type of question. But remember ATP. So ATP, this you can think of it as one of the questions that can be asked. For example, what is rigor mortis? So what is rigor mortis? What's cause rigor mortis? Exactly. So if you don't have any ATP production, what happens in muscle? Muscle cannot contract or stay contracted as is. Because remember, you need to have an ATP, transformation ATP, for the myosin to relax or to liberate itself from the actin. And every time you have a new ATP, you have the contraction, you have the relaxation. So now, if you don't have it, the actin and myosin are going to stick together, and this is what you have the contraction of those muscles, which you call rigor mortis. So that is one of the higher questions. So it's a question that has to do with breathing, but mostly has to do with muscle physiology and pathology. So remember, that is logic. You need to have oxygen to have metabolism, and any metabolism is going to produce CO2. That is the logic of it. But remember as well, and that is also biochemistry and macrobiology even, you're going to have two aspects of it, the aerobic metabolism versus anaerobic metabolism. And the anaerobic metabolism, you don't need much of oxygen, non-oxygen whatsoever. And the aerobic, you love oxygen. And this is what you did in infectious disease not a long time ago. So the conduction of exchange, where you're going to have gas exchange between the blood and the alveoli, you have three areas in here, and need to know that. That is an anatomic question, physiology question, and even biochemistry question sometimes. But anatomy for sure, and physiology. So you're going to have that in bronchioles, alveolar ducts, and alveoli. So the other question that can be asked within these three area of gas exchange is going to be histo picture. It can put you in a histo picture that you need to know about the lung histology and to need to recognize the bronchioles, alveolar duct, and alveoli. And remember, one thing that tells you this is the change of the cells and also the dispersion of the muscles, the smooth muscle that you are not going to find there. Uh, and we did cover this when we did respiration. If you want, we can review it uh, another day when we finish with the physiology. So bronchoalveolar duct and alveoli. So the oxygen delivered to tissue obviously is going to depend on your heart pump, cardiac output. More cardiac output, more blood goes out, more oxygen goes out, unless obviously you are in stage of cyanosis and respiratory problem where there's not much of oxygen that would be given. So any heart failure is going to lead you to the decrease of oxygen and cyanosis, which is the discoloration, blue discoloration of extremities mostly starting, and marble-looking skin, and blue discoloration of the lips and even the nose. So this lead to ischemia. Although you need to do the differentiation between the ischemic as obstruction versus the ischemic without obstruction. Then you have the hemoglobin. Hemoglobin, which is the biggest carrier for the oxygen and CO2. And remember, you might have multiple type of problem in hemoglobin, either as the cells, you don't have much of red cells, or you have an issue with the hemoglobin, structural issues, amino acid exchange, for example, the shape of the cells that is totally different, and also the type of hemoglobin. And remember that hemoglobin, fetal hemoglobin, is one of the hemoglobin that love oxygen and is going to take as much as oxygen as possible. And this is why one of the reasons that many of the hemoglobinopathy are going to have an increase of number of the fetal hemoglobin to catch up actually this oxygen need, and this is what you need to look for when you do the lab for any type of anemia that has to do with hemoglobinopathy. And then you're going to have the affinity of oxygen for of hemoglobin for oxygen, meaning how much you can carry. Normally, 75% can be the good number, but remember, sometimes you're going to have gases that are going to push out the oxygen, or you're going to have an issue within the structure of hemoglobin that cannot carry as much as oxygen as possible. So, and then the values. So normal value for PO2, and this value that you need to know is going to be 80 millimeter of mercury. The arterial CO2 that you need to know is going to be 40. So once again, why this is important is because for the pH, to calculate pH and see if there is acidosis or alkalosis and how you're going to deal with it. And then you're going to have saturation of oxygen that's supposed to be 92 up to 98%. So this is what I was saying. You're going to have the first exchange would be within the alveoli. Well, it's going to depend on the but less than 60%, yeah. So oxygen exchange within the alveoli going to the arterial circulation, exchange within the cell respiration, CO2 is rejected and go back to the lung through the vein system and release of oxygen. So that the release of CO2, that is the common pathways. So some of the equation that that can be asked sometimes uh, for your steps is about first of all understanding the causes of hypoxemia. Those are high yield questions. is to know the exchange, alveolar arterial exchange gradient, and to understand the alveolar gas equations that can be given. So the representation would be the big A would be alveolar. The small a would be arterial. And then you're going to have anything that is I is inspiration, anything that is E would be expiration. And you usually you're going to have kind of prediction of what is going to happen. So normally, remember, by exchange, you're going to have a big exchange within pressure, alveolar pressure of oxygen that are going to be exchanged with the alveolar CO2. So giving oxygen and taking CO2, that is PaO2 and PaCO2. PiO2, once again, is the oxygen pressure that is inspired, and the normal value, which I suggest you to keep in mind. You don't have to memorize it because sometimes they would give you the value in the back of the lab thing, but sometimes it can save time. If you can remember it, is fine. If you don't, it's fine as well. PiO2 is 150 millimeter mercury. And then PaCO2, which is the alveolar PCO2 that you know. And the exchange between all this is going to be the CO2 production divided by the oxygen consumption. This formula, I should put it separately in red. This formula is a formula that you need to know because this is a logic type of formula. Is everything that you're going to produce as CO2 divided by how much oxygen consumed. Remember that CO2 is a kind of constant. The oxygen consumption depend on your metabolism, depend what you're going to do. If you run, obviously consumption will be higher. If you don't and sit down, then the consumption is going to be lower. But the CO2 production, your metabolism as well can change depending on your metabolism, but you have a certain constant for both of them. So normally the respiratory exchange is going to be 80%, so 0.8. Keep this number as well in mind for some questions. So the gradient, what is the gradient? Is the exchange itself, and how you're going to calculate the alveolar arterial gradient is going to be the difference between the alveolar PO2. One is the systemic PO2 or the arterial PO2. Normally, you're going to have arterial alveolar arterial gradient should be around 15 millimeter mercury starting from 4 years old, and then you add by age you add 4, so about 4 years old. So you're going to have the equilibration of the oxygen across the alveolar gas and pulmonary capillary blood. So this is the exchange in one word. So so remember, in the lung, the artery are vein and vein are artery. So do not mix up both of them. But the value are going to be the venous for artery and the arterial for venous. And so the capillary itself is going to be, you need to look at it differently from the tissue. You need to look at it, the capillary closer to the artery and capillary far from the artery. Remember, the post is going to be richer in oxygen and the pre is going to be richer in CO2. And remember that this type of changes, you add always 4 because you're going to have it increase with age. More you get older and more the systemic arterial is going to increase. So because your metabolism is higher and the size of the body is much higher, so you need to have this equilibrium. So what happened when you have hypoxemia? Obviously, you have the gradient between alveolar that increase, and where you're going to find this type of increased alveolar arterial gradient increase are going to be in area where there's a mismatch. For example, VQ mismatch, pulmonary fibrosis, the shunts. So in pulmonary fibrosis, you don't have much of tissue available for the exchange, but the small amount of tissue that you have for the exchange, you need to do the most of it, because everything is replaced by fibrosis. The shunts, usually it goes toward the CO2 or towards the oxygen, depending on what you're going to have. And that it means, as the shunt, it means you're going to bypass many systems. Beacon mismatch, remember the pole versus the base of the lungs that are going to be different. We're going to talk about it uh, soon. So this is why understanding this make you understand what are the causes of hypoxemia. So you're going to have at least five big causes. The first one is the high altitude. In that situation, you don't have much of oxygen, but you're going to, like you saw, make more CO2. But in high altitude, the differentiation between the alveolar and the arterial gradient is going to be normal. Keep that in mind. This is a question. Normal alveolar arterial gradient. Remember, by definition, hypoxemia is the decrease of the pressure of arterial oxygen. This is why you have mismatch. The gradient is going to increase in case of severe hypoxemia. So in high altitude, as we saw earlier, what's going to happen? Normally, the barometric pressure we saw it as 0. But in this situation, it's going to be negative, so it's going to decrease. If you have a decreased barometric pressure, remember what's going to happen. You're going to have the inspiratory pressure that is on oxygen that is going to decrease as well with it, because you don't have much of oxygen. And remember, more you go to altitude, and more the pressure is going to kind of decrease. And so what's going to happen in this situation is that you don't have much of exchange between the inspiratory oxygen, and you're going to have kind of constant for the FiO2, which will be around 21%, but everything else is going to decrease. So the end product of all this is that you're going to have a decrease of the pressure arterial oxygen. And all this is because the barometric pressure is negative or is decreased. But remember, once again, that the alveolar arterial gradient is going to be the same. The why is going to be the same for one reason is the exchange between the oxygen and CO2 doesn't change. It's going to be the same thing. The alveoli and the blood are normal, so the exchange will be normal. The only difference is that the pressure did change, would change the amount of oxygen that is in the air. So in that situation, physiologically, your body need to adapt to those situations differently as if it was a disease. But if you let it too long, remember, you can have a pulmonary edema, you can have pulmonary cerebral edema, and vomiting, nausea. Hypoventilation. So the hypoventilation, this one as well, is decreased by definition. Hypoventilation, decreased frequency of breathing. This as well, you're going to have a normal AA gradients. So it's just that the amount or the frequency of bringing oxygen is going to be delayed or decrease, which we call the minute ventilation actually. So how are you going to calculate that? You can calculate by respiratory rate by tidal volume. And yesterday we did questions a bit similar to this one. So if you have decrease of ventilation, you're going to decrease of pulmonary alveolar oxygen. That is logic because you bring lesser, as frequency, you bring lesser oxygen. It's like I'm asking you to breathe 26 a minute versus breathe 10 a minute. If I ask you to breathe 10 minutes, you conserve your metabolism, you conserve the amount of oxygen that is in the air. You don't breathe it in faster. So if you breathe 26, you're going to consume all that oxygen faster. So this is why the oxygen that would go to the alveoli will be decreased. That is logic. So what happened in that situation? Remember that the CO2 is still coming, and it's because of ventilation that the CO2 should come out. In that situation, if you decrease it, pure CO2 is going to increase, and the overall oxygen is not going to change. It's going to decrease because you bring less. So in that situation, the frequency of the FiO to oxygen and the barometric don't change in the overall gases equation because that's not disease. It's just PB did not change. It's just ventilation that is decreasing for many reasons, voluntarily or involuntarily. So you need to look in this situation, the alveoli and the exchange is still totally normal. Anything that is pressure outside is going to be normal, and the oxygen itself is going to be normal. So if it become abnormal, so if the need of oxygen is going to increase, in that situation, you're going to see hyperventilation increase, unless this is someone that has hematoma, thoracic hematoma, for example. In that situation, hyperventilation is going to decrease, but or pneumothorax. But even pneumothorax, they're going to try to hyperventilate a little bit, but it's so painful. But uh, but if the need is there, then the ventilation is going to take over and let the disease. So in case of the VQ mismatch, the overall gradient is going to increase. And remember, volume versus VQ mismatch is that in one area in the base you have a lot of vascularization, and in top you have a lot of volume, more air. So that is a mismatch. In the middle you have as much as volume exchange versus circulation. That will be almost the same. So if you don't have much of circulation, so it means you have less of oxygen. More circulation you're going to have, more oxygen is going to be brought. So this is why you're going to see that in the alveoli, the air is not going to change, and but it's going to increase with the mismatch. Diffusion limitation. And diffusion limitation here as well is like the mismatch. You're going to have an increase of the alveolar arterial gradient. The example here, what does it mean diffusion limitation? It means that you have problem. You have problem of the amount of alveoli, you have problem of the diffusion itself, you have problem as the spacing between the arterial versus the alveolar, or capillary versus the alveolar, and all these are going to have an impact of the exchange of gases. So this is why it's limitation, and this is why the gradient between the alveoli and the arterial are going to increase, and they're going to change. What are the example in here? So keep them in mind because this is what they're going to give you. Pulmonary fibrosis. In pulmonary fibrosis, you have scar tissue, so you have less of alveoli, so the exchange is going to be totally different and decrease. So you're going to have an increased diffusion distance for diffusion, meaning that imagine that you're going to have spot that has fibrosis, another spot that do not have fibrosis, another spot that have fibrosis. So the gas need to use, like I said, these area that are not fibrotic as much as possible to maintain a certain value. This is why the number between the exchange are going to be higher as a gradient because they're going to use it as much as possible. It's like, for example, let's say that they throw at you $1 million, and they're going to ask you, well, go try to grab as much as you can. So what you're going to do, you're going to run all over the place, not specifically what place, wherever you see $1 on the floor, this is what you're going to pick up. This is exactly the diffusion limitation that you're going to have. So pulmonary edema, obviously you're going to have an edema between I imagine that. Give it to me. I need it now. So the pulmonary edema is going to have water between the alveoli and the blood vessel, interstitial level. So what does it mean? It means that the oxygen is going to be lost within the water, within the edema itself. So you don't have much surface area in that case, and the diffusion distance is going to increase because the spacing is going to increase. And this is why pulmonary edema is one of the number one emergency because they drown and there's no much of exchange happening until you remove the excess of water. Now the right to left shunts, this one as well is going to have an increase of the gradient, and the right to left, what does it mean? It means you have more CO2 going to the other side that should be oxygenated. So what does it mean? It means that you're going to have lower oxygen, more CO2, and you're going to have a mix between them. Uh, and then you're going to have uh, kind of all the rich of oxygen is going to be diluted and non-shunted, the one that you're going to breathe in. But anything that is blood is going to be mixed up between, and those pretty much people that do have the hole in their heart. This is what they're going to have. So obviously the hypoxia, it's the delivery. It's the delivery of oxygen within tissue that is going to decrease, and so if you have delivery oxygen decrease, so the oxygen itself is going to be a problem. So hypoxemia has to do with all the changes of oxygen that within the alveoli, atmospheric pressure, and here is mostly the delivery itself. So blood, heart are going to be the biggest. The heart, the blood, and vascular, obviously, blood vessels are going to be the big causes of hypoxia. Uh, so here you have some formula that you need to understand and you need to keep in mind. They might ask you to calculate. So oxygen content in the blood, how you calculate that is the oxygen binding capacity that you multiply by the percentage of saturation that you add the dissolved oxygen. Uh, or how you're going to calculate the oxygen bound to hemoglobin is the oxygen binding capacity multiplied by the saturation, percent of saturation, and you're going to have oxygen bound to hemoglobin. Um, and the delivery itself is going to have to do with cardiac output. So it's going to be cardiac output multiplied by the oxygen content of blood. And those, once again, we need to know them. So what are the causes of hypoxia? Once again, like I said, it can be either the red cells, it can be the heart, or it can be the blood vessels. So anything that has to have to do with the blockage is atherosclerotic plaque, emboli, stenosis. All these are going to increase the hypoxia to the tissue. And they all lead you to ischemia, and from ischemia can lead you to necrosis. Remember, ischemia lead you to atrophy, as the total ischemia and obstruction can lead you to necrosis. Need to be acute. So decreased cardiac output, but decreasing blood will decrease blood flow. If you have decreased blood flow, you don't have much oxygen going. The arterial pressure in hypoxemia, for example, is one of them, which decrease the oxygen content in the blood. The anemia versus CO poisoning would be the same thing. Is the oxygen taking place, CO taking place of oxygen, or there's not enough hemoglobin or red cells to have oxygen delivered. Exotic toxic, that is cyanide, remember that. And this is a big question for cyanide because there's a lot of cyanide poisoning. So cyanide poisoning, what's going to happen is you're going to have decreased oxygen utilization by tissue. So it's mostly the mitochondria that are going to be poisoned. Remember that. Once again, has multiple questions about it. CO poisoning, this is common, like I said, during the winter time, you're going to see a lot of these cases, and that is just the CO taking place of oxygen. They are competitive between each other. So the oxygen delivery will decrease, oxygen content in the blood is going to decrease. And this value, this one left, it's in blue. It has been questioned. Sometimes you're going to see between 200 and 400 as the number goes. But the cardiac output, uh, the, um, the poisoning, the cyanide poisoning or CO poisoning, monoxide, carbon, don't mix up with cardiac output, is going to bind to an hemoglobin 200 times greater affinity. This is why they love and push out oxygen. And so if you look at it in the curve, this has another question about it, beside the number, is the oxygen hemoglobin dissociation curve is going to shift to the left. Keep that in mind. It's a question. We're going to do the dissociation curve probably tomorrow. So remember, anytime you don't have much of oxygen, anytime you have hypoxia, you're going to have headache. That is the first sign. Um, why is it not in red but in blue? CO2 will be blue, CO will be red, pink actually. Hmm. Yeah, ischemia, usually you're going to see it very purple, red, or darker than that. It can lead to bluish coloration, ischemia. Oh yeah, yeah, that too. I should put it in red or pink. Yeah, I should put it in pink to remember CO. Yeah, that is a good the sherry pink or sherry red as they call it. They call it sherry red actually, but for me I saw them pink, so it can be sherry red. But I remember sherry red as the how they this is a keyword actually. Sherry red patient. Um, so the cause of the ischemia is about decreasing blood flow. You know that atherosclerosis or Budd-Chiari syndrome. Which, give me the definition of Budd-Chiari syndrome. I'm deep. Come on, we did that multiple times. Kevin, what is Budd-Chiari syndrome? Which one? You are correct, but you're not precise. The post-hepatic vein. Post-hepatic vein, the vein that comes out, that go to join the vena cava. Yes, and do not mix it up with Chiari syndrome. So remember respiratory system function, the breathing, the gas exchange is the main one, the regulation of pH, voice production, that is covered in ENT, olfaction. So the olfactory, Yakov, the olfactory nerve go through which bone, which part? Can be from plate is incomplete. Yes. Keep it from plates of the ethmoid bone. And you're going to have all the protection, remember, from respiratory, you're going to have the LGA there. Definitions: ventilation, movement of air. External respiration is anything gas that comes from outside. Transport. Internal respiration is between the blood and tissue. Uh, so remember that the lung oxygen uptake rate, it's the cell oxygen utilization rate. More metabolism increase, more the oxygen uptake is going to be higher. Cell oxygen production rate, CO2 production rate is going to depend on the lung CO2 release rate. So more your metabolism is high, more you're going to hyperventilate and you're going to release the CO2. Minute ventilation as well, definition is total amount of air moved into and out the respiratory system per minute. And the respiratory rate or frequency is number of breathing that you're going to have. Ventilation perfusion coupling, that is the exchange between the alveoli versus the capillaries. So these you're going to have multiple shunts here. So if you have decrease of oxygen, obviously you're going to have an increase of CO2. But remember, here what will happen is this is an artery, this is a vein, has the capillaries, and everything that comes within the vein, post capillary, is going to be rich in oxygen. So if you have decrease of PO2, obviously PCO2 are going to increase. So what happened to your blood vessels in that case, if the oxygen decrease, you're going to have vasoconstriction. So you're going to have a reduction of the level of ventilation, and you have decrease of the perfusion. So vasoconstriction. So now, if you have an increase of the oxygen and decrease of the PCO2, what's going to happen? You don't have a good, because of the PCO2 that decrease in alveoli, the enhanced alveolar ventilation become inadequate perfusion. So you're going to have vasodilation, and vasodilation bring more of the blood that will enhance the ventilation and the exchange to have more oxygen, to be more CO2 to be eliminated, and more oxygen going towards the blood. So and here is about the pressure. Like I said, for the pH is going to be important. For the exchange of gas will be important. So sometimes they will ask you values for this one. So remember that within the alveoli, expired air, you're going to have something as 120 millimeters mercury of pressure of oxygen as expiration, and PCO2 is going to be 27. So within the alveoli, the PO2 would be 104 and the PCO2 would be 40. But within the venous blood in the lung, the PO2 would be 104 and PCO2 would be 40. And this is the exchange that is going to happen. So all this pressure goes to the venous capillaries within the, or venous blood within the lung. So you see there's not much of a difference between the pressure. So this is going to be transported. Once it starts to be transported going to the heart, the pressure is going to change. There's many why the pressure is going to change. Some pressure because the oxygen will be diffused within the blood, and some will be sticking within the hemoglobin. But 95% of pressure of oxygen will be in the arterial, and actually up to here still in the venous pulmonary, bigger pulmonary vessels. PCO2 do not change 40. It goes to the left heart, and then when it arrives to the tissue, the PO2 and PCO2 did not change much. Then you have the exchange. So by the exchange of tissue, you see that the PO2 decreased to 40 and PCO2 increased to 45. Within the tissue itself, the PO2 was 20 that would be exchanged, and the PCO2 is 46 that would be exchanged. And some, remember, once again, you have loss of some of the gases within plasma and within the interstitial stuff. uh, there's always loss somewhere. Like when you pee, you have some that is going to stay inside. And then so the pressure within the oxygen is going to change within the venous system, where the PO2 will be 40 and PCO2 will be 45. And remember, once again, this is values that can give you in this case to determine if you have if you have respiratory acidosis or not. At this point, within the vein, you're going to have respiratory acidosis because the PO2 is 40. And then it goes to the right, and then it will go to the lung. Once it comes to the lung, anything that is inspired, you see the PO2 inspired, you have more oxygen, so it would be 160, but the PCO2 would be zero point 0.3. Keep that in mind. And then the exchange will happen, the same thing. From 40, it become 104, and for 45, you're going to give CO2, it become 40. And the system keep back again. So values in here are important to know, and the exchange at what level the value are going to change are going to be as important as well. Some more of the definition. Compliance is the sensibility of the respiratory. We saw that, and that the surfactant will be very important. How they going to increase in size and increase surface area. So it's like elasticity, increasing elasticity or not, same deal. And how you're going to calculate the compliance is going to be the volume divided by the pressure within the lung. And this is how you're going to have the compliance of it. So the compliance is going to increase in emphysema. Why? Because emphysema, the alveoli are going to start to fuse together. So you're going to have more surface area. But the problem is that the elasticity and the exchange will be decreased because they're not healthy alveoli. And for fibrosis, because you have scar tissue, you have less alveoli. This is why the compliance is going to be lesser, so less surface area of exchange. Pulmonary edema will be the same thing, and the worse the RSD because of all the edema and the inflammatory process, they're going to decrease the pulmonary compliance. Obviously, if you have problem with chest wall, the lung and the chest cannot expand. If the chest cannot expand, so do your lungs. So if your lungs do not expand, you don't have much of compliance and you don't have much of gas exchange within your alveoli. Keep that in mind. So fibrosis, edema, respiratory distress syndrome, that decrease, and in emphysema, it's increase. Doesn't mean that they have good exchange. No, once again, they fuse together. Elastance, this is another definition. The elastance is going to be the elasticity property of the lung. How much recoil you're going to have. This is why it's different from compliance. Compliance is extended. Distandability in here is how much it can back to its original position. This is why it's going to be the contrary. So the elastance is going to go with the pressure divided by volume. Bigger the pressure is going to be, more normally should increase it in size to have volume, and more volume you're going to have, more elastance you're going to have because you stand in it, so it becomes compliance. So if you don't have elastance, once again, to make it going back to its original position, is going to collapse inside. And normally the chest wall will expand your lungs, so it's going to be the expansion outward, and that is elasticity as well. Okay, we're going to stop here today. I think I gave you a lot of information today. And tomorrow we're going to, the first hour, we do question as usual, and the 2 other hours we do physiology. We try to do physiology. Hopefully all this is a reminder, you know more. You're supposed to know this material, but it's a refreshment, especially for critical areas, as the numbers and formulas. Any question? Okay, so see you tomorrow at 10 and study, study, study.